So I will be presenting what I call the case of AR. And this is a case that truly did keep me up at night, and one that raises several issues, many of which are related to siblings and bone marrow donation. And the fundamental question, can a parent protect the interests of both the donor and the recipient? Now, from a format standpoint, I'm going to take about 5 minutes to present this case, and then I'll be handing over the podium to Paula first and then Lainey next, both of whom will provide their own perspectives on the issues that this case raises. And one other formatting note, we won't have any questions or an answer session following this session, but we will reserve those for the panel discussion that's being held at noon. So AR was a 15-year-old boy who presented with nonspecific generalized symptoms, including headache, sore throat, fever, and night sweats. And his physical exam was notable for subconjunctival masses, and his blood work showed a high white blood cell count of 43,000. At the time of these symptoms and initial exam and workup, AR was in state custody and incarcerated at a state correctional facility for a history of sexual assault of his younger half-sister. Recognizing the need for further workup, given his high white count and initial symptoms, AR was transferred to a tertiary care center. There, he was eventually diagnosed with acute myelogenous leukemia, or AML. He began intensive induction chemotherapy with a predicted cure rate of about 50%. And although his leukemia was initially refractory to the standard induction chemotherapy, remission was ultimately achieved. However, despite continued aggressive conventional chemotherapy, an early bone marrow relapse was confirmed 4 months after initiation of therapy. In patients with refractory AML, like AR, the best option for cure is usually a bone marrow transplant. Further chemotherapy is a possible alternative to this, but has an inferior likelihood of cure. And a third potential option is non-curative experimental therapy. It was estimated that a bone marrow transplant offered AR about a 40% chance of long-term disease-free survival if he had an HLA-matched sibling donor. This likelihood would be less if he had an HLA-matched but unrelated donor, and even less if he had an unmatched unrelated donor. A family and unrelated donor search had already been initiated 6 weeks following AR's diagnosis. And the results of that search were already known at the time a transplant became his best treatment option. The results had identified his 9-year-old sister, the victim of his prior sexual assault, as an identical match. Subsequently, this sister underwent a psychological assessment to determine her mental status and emotional suitability to serve as a donor. Notably, this assessment occurred after her compatibility status was known and involved a 50-minute conversation with the psychiatrist consulted on the case and her mother, who was also AR's mother. Although the mother would not allow the psychiatrist to talk with her daughter about the past abuse, nor talk to her without her in the room, it was felt that the sister had age-appropriate concerns and anxieties, as well as an age-appropriate understanding of the process of bone marrow donation, and it was concluded that the interview did not provide any information to suggest that she was at high risk of traumatization from the bone marrow transplant due to the previous experience with her brother. The psychiatrist did note, though, that AR's sister never received any counseling about the past abuse, and it was possible that she simply avoided overt manifestation of the trauma through defensive denial. An ethics consult was obtained around this time to determine the appropriateness of utilizing AR's sister as a donor. The consultant recommended that a guardian ad litem should be sought on the sister's behalf. A few months later, after another round of chemotherapy prompted by AR's initial reluctance to have a transplant, AR expressed a desire to go forward with it. A bone marrow transplant with his sister as the donor was performed about 7 months after AR's initial diagnosis. A guardian ad litem for the sister was not pursued. AR's sister had an uncomplicated post-op recovery. AR also had a relatively uneventful course of donor engraftment and was discharged to the state correctional facility 10 months after his initial diagnosis. He, however, suffered a second relapse of his AML 10 months later. He decided against reinduction chemotherapy at that time, and his mother did not challenge his decision. He died 2 months later. Very little is known about the sister's conceptualization of her donor experience and its impact on her psychological well-being. This case, as you can imagine, raises several questions, 4 of which I'd like to pose here, and many of these we'll try to address in the following discussion. First, should prisoners have access to costly medical interventions like bone marrow transplants? Second, how should clinicians and consultants manage their potentially conflicting feelings of empathy and act on those feelings for the patient, donor, and mother? Should a minor sibling, and this is probably the most provocative question, be permitted to act as a transplant donor when the recipient sexually assaulted her in the past? And finally, should parental permission for the use of bone marrow obtained from a minor sibling be considered valid? And what are the broader policy implications for sibling donor bone marrow transplant? So with those questions, I'd like to turn over the podium to Paula.
Oy vey. You know, I like what Dr. Faust had said about the likelihood of you remembering something. You might remember one thing, plus or minus one. At this point, it doesn't really matter what you remember. I think what's more important is how you feel. And maybe a memory of how you feel is what you'll take away from this. Ethics committees and ethicists, we get involved in highly emotional situations that test our tolerance for behaviors outside of what's considered normal, situations where there is definitely a yuck factor, situations that provoke feelings of emotional and moral distress. Intervention in these sensitive situations requires certain core competencies as articulated by the ASBH document on core competencies. So if you want to raise your right hand and say, I promise to be tolerant and patient and compassionate. I will listen well. I will communicate interest, respect, and support and empathy. I will welcome people with difficult problems, those who may be emotionally distraught or those who have minority views, so they can be fully and respectfully heard. And I will work constructively with these feelings. We must be honest about our own limitations, a need for more knowledge, and how our agendas and values shape consultations. We need to demonstrate prudence and humility and acknowledge possible areas of conflict between our personal moral views and interests and our role in conducting consultations. So I ask, what competencies would have strengthened the ethical analysis and probably the outcome of this case? So you know this, okay? We're not going to go over this. But what my presentation is actually going to focus on the context of sibling incest. And note that patient preferences really should not be there. I don't know how that got there. So this is really more about what are the contextual features of a case. And I think you all already know this, but family issues that could influence treatment decisions, provider issues, are there financial and economic factors, religion, culture, limits on confidentiality, and so on and so forth. So we can't really deliberate about the right actions to be taken if the context is not taken into consideration. And frankly, the context is really what makes the practice of bioethics so rich and so complicated. The context informs your analysis regarding ethically defensible actions. In this case, the context brought up some very difficult questions and answers, and I feel compelled to state that if the context of this case was better evaluated and attended to, the outcome may have been different. I was looking at the obituary for Dr. Pellegrino in the Washington Post one morning, and this was really very relevant. The capacity to make moral judgments and to be self-critical is part of being an educated person, and that's what I do with ethics. I don't set out to make trouble, but when I do cause a stir, it's only because I raise questions that strike me as unavoidable. So I'm going to put forward some unavoidable questions. Could sibling incest ever be considered morally and socially acceptable? Does sibling incest always result in harm? Are the perpetrators of harm, in this case, also victims? Are our emotions as clinicians morally relevant to clinical practice? And moreover, what do we do with them? And was the process of ethics consultation in this case lacking? So let's look at the phenomenon of sibling incest. Sibling incest is defined as sexual contact between a sibling dyad that is experienced by the victim as traumatic, and sexual behavior between siblings that is not age-appropriate, not transitory, not motivated by developmentally mutually appropriate curiosity. And that's a definition by Cafaro and Concafaro. So it can refer to abuse that takes place between brothers, sisters, as well as between half-siblings, step-siblings, and adoptive siblings. It's estimated that approximately 15% of all people report some kind of sexual activity with a sibling in childhood. Finkelhor says that between 2% and 4% of people have been sexually victimized by a sibling, as the sexual contact involves some degree of coercion. It is true that children of all ages generally engage in some degree of sexual interactions between themselves and as well as self-exploration. In fact, it's considered normal, healthy. Borges's research tells us that as siblings are generally close in age and locational proximity, it stands to reason that the opportunity for sexual exploration between siblings is fairly high. And that, if appropriate and based on mutual curiosity, then these activities are not deemed to be harmful or distressing, either in childhood or later in adulthood. Now, for the sexual exploration to be deemed appropriate, the interaction is between children of a similar developmental age, where prior knowledge and experience and physical and emotional development are on par with each other. However, some writers strongly disagree with this statement. Now let's briefly just look at, where did the taboo of incest originate? A lot of writings about that. In 1891, Westermarck proposed that humans possess an evolved inbreeding avoidance mechanism such that persons exposed to one another for a significant duration during childhood of one of the pair will later each be averse to sex with the other. Current researchers, Fessler and Navarrete, they propose that an individual's attitude towards sex with close kin is a product of two factors. First, an endogenous contribution produced by inbreeding avoidance mechanisms, and secondly, an exogenous contribution produced by cultural prescriptions internalized to varying degrees. So they conclude the view that moral reasoning is influenced by intuition, emotions, and other inchoate experiences that are in part the products of evolved psychological mechanisms. Another question: does incest always result in harm? I will say that enough studies conclude with a resounding yes. The characteristics of brother-sister incest and its associated psychological and social distress does not differ from the characteristics of father-daughter incest, and brother-sister incest is really very understudied compared with father-daughter incest. Some authors have suggested that sibling incest may be less harmful, while others have stated that an age difference of 5 years or more between the victim and the brother is more damaging. A second factor that leads to damage is the presence of force and then the nature of the sex act itself. Brother-sister incest usually occurs in relationship with a power differential and that because of the power given to males over females in our society, this differential remains true even when the brother is the same age. Furthermore, it is not benign even when the age difference is small and or when one or more report the experience as positive, because studies demonstrate victims suffer from excessive guilt. From ages 6 to 13, children are able to conceptualize the abusive act as wrong. They feel guilty, worthless, and a lot of shame. So there are known categories of harm to victims of sibling incest. They include developmental and mental health, distorted sense of self, difficulty with relationships, premature sexualization, confusion about sexuality, lifelong problems, including in areas of marriage and work and parenting. And from a mental health standpoint, higher incidence of mental health disorders like depression, PTSD, anxiety, major depressive disorder. Are you depressed now? Okay. So the third question, are perpetrators of harm also victims? I know Lainey Friedman Ross is going to talk about intimate families and where perhaps one child's interest can be traded for another. And that's in a family that's healthy. Let's talk just a little bit about the family dynamics that are precursors for a sibling incest. Adolescent sibling incest offenders reported significantly more marital discord, parental rejection, physical discipline, negative family atmosphere, parental absence, and general dissatisfaction with relationships. They were also likely to be victims of childhood sexual abuse and more likely to have a younger child in the family. There is enmeshment and poor boundaries, and that's really a hallmark in these at-risk families. Often the mother is over-involved with the offender and not allowing the individual to take responsibility for his actions. Part of this is because the offender may feel that he has some kind of a privileged position with a parent, and it is connected to the offender's perception of his own status, because these are families where the family dynamics incur what we call parentification, where the offender assumes premature and excessive caretaking responsibilities. So a parentified child is going to believe that he has similar power and control as the parent. And the abuse is a means to relieve frustration, anger, and hurt. And then you can see then there's a lot of triangulation to act on the parent's behalf. And ultimately, power and control are the coping styles of the adolescent. More, there's lack of privacy, a lot of sexualized talk, access to sexual materials, sanctioned by the parents. There could be inappropriate touching. And another study indicated that offenders observed intercourse and sexual activity between their parents. Briefly about the mothers. Research has identified maternal characteristics consistent with collusion, meaning the mother is consciously or unconsciously aware of the abuse prior to the disclosure, but using denial upon disclosure, and that's the evidence of collusion. Mothers with abuse histories often were considered to be passive and conflict avoidant, which matches the collusive description of not knowing about the abuse. So, are our emotions as clinicians morally relevant to clinical practice? And what do we do with them? For instance, how are you feeling now? I would answer again with a resounding yes. Our emotions are morally relevant, and the issue is what we do with the emotions. It's having the requisite insight to know when you're morally or emotionally distressed and how to diffuse and act on these insights in an adaptive manner. In this particular case, it appears the process was rather sterile. There was a reliance on the psychiatrist's expertise. It seemed to prevent the necessary process of moral deliberation. And it also seems as though the process perhaps protected those involved, meaning the clinicians and perhaps the boy, from having to face emotions of sadness or rage or disgust. I particularly like Jodi Halpern's work on clinical empathy, she tells us that we must move from detached concern to emotional knowing, where one is moved by another's experience and demonstrates attunement. Empathy does not always occur naturally. It will break down to the degree that one's own unresolved issues begin to surface. And empathy sometimes really requires an act of will in order to maintain it. So you're probably familiar, maybe not familiar with the term countertransference. I was trained as a therapist and as a social worker, worked for 20 years, and I experienced a lot of countertransference. Even though as an ethicist, you're not a therapist, you really are involved in very intimate situations where I believe countertransference does occur. The original definition of countertransference emanated, as you know, from Freud's work. He defined it as the analyst's unconscious and defensive reaction to the patient's transference. I'm using more of a post-Freud, a generic definition, which encompasses all therapists or the clinician's reactions, conscious and unconscious, that serve as a tool. And I particularly like the second sentence in this slide where it says, the insight that may be gleaned from countertransference can deepen therapists' awareness of relationship dynamics and provide valuable information about the course of treatment. So what happens when we experience morally objectionable individuals? What happens with regard to countertransference? Well, clinicians who work with morally objectionable patients inevitably come to a realization that this is not a dispassionate technical endeavor. The ability to step back and evaluate emotions and reactions is critical. So what are some of the countertransference reactions? I'm not going to go through all of these, but I do believe that there were several that may have been at play in this case. Isolation of affect, which is experiencing an event without emotion, perhaps, was demonstrated in this case. Malignant pseudo-identification occurs where the clinician will over-identify with the patient to the extent where the patient's acts will be defended. And it can result in a lot of splitting behavior on the part of staff. Some staff will adamantly defend the patient, some will not. This attunement would be construed as dangerous and a misapplication of empathy. And in looking at this case, I suspect that this was one of the reactions. Assumption of similarity, it's a belief that others are like oneself. This also could have occurred with this case, maybe on an unconscious level. So in terms of clinical empathy, I've suggested that we should have empathy and that countertransference plays a role in its development and our ability to act on it therapeutically. So while the adolescent does deserve empathy, this does not translate into an absolute ethical obligation to serve his needs at the expense of his sister. I wonder, given his place in the family system, did he feel entitled to the bone marrow? For the mother, was her decision akin to Sophie's choice? What were her motivations? Surely she was a participant in the family psychodrama. Her actions either advertently or inadvertently reflected a clear preference for her son. Was the mother a victim of sexual abuse herself? If so, had she minimized its power? What was the mother's capability for insight, coping mechanisms? And for the 9-year-old child, sadly, if clinical empathy occurred, it doesn't appear as if it was addressed, and it certainly looks like it was misapplied. So in my humble opinion, the 9-year-old female should never have been compelled to donate, let alone be tested as a donor match. She required protection because she was vulnerable. It's highly likely the child will and is suffering repercussions. I believe the personhood of the child was violated in service of her adolescent brother. The clinical context appears to have been ignored and did not appear to inform the outcome of the case. The value of preservation of life for the boy outweighed the value of child protection. And while all involved can be considered victims, the 9-year-old child really suffered the greatest harm. and I do believe there was a misapplication of clinical empathy. Thank you.
Feel free to take a deep sigh after that. I'm going to start with my disclosures. Next slide, please. So first, I have no financial conflicts. Oh, I guess I'm doing my slides. There we go. Wasn't here last year. Okay, no financial conflicts related to this talk. I want to make a couple of acknowledgments. First, my comments on this case were originally published in the Journal of Clinical Ethics. It was co-authored by Walter Glann, and I want to thank Walter publicly. I also want to mention, and I'll be talking a lot about it at the second half of my talk, which is that I was the lead author for the American Academy of Pediatrics statement on children as hematopoietic stem cell donors, which was originally published in Pediatrics in 2010, and I'm proud to say it was recently reaffirmed despite a lot of controversy, as I'll talk about. I also want to disclose that I admire Norm Faust. I'm fine with being second to Norm in everything. I, too, was influenced by Ramsey at Princeton and by Jay Katz at Yale. But I was fascinated as I heard Norm talk about being discouraged by all of his mentors. So I have to say that in 1988, in the middle of my residency, I flew up to Wisconsin. I was at Children's Hospital Philadelphia. I flew up to Wisconsin for a wedding of a mutual friend, John Andrews, and I actually arranged to have breakfast with the famous Norm Faust. And at breakfast, I asked Norm, should I go and get my PhD in philosophy? And Norm looked at me and said, absolutely not, waste of time. I didn't listen to Norm, but I have to tell you that I have asked Norm for advice on every single career decision I've ever made. I've ignored him on all but one. And the only decision that I think I made that was wrong was the one where I actually followed his advice. But despite that, I would never make a decision without asking Norm. So I want to thank publicly Norm. I also want to thank Doug and Ben for inviting me back to the conference. Being second to Norm is wonderful. And also thank Doug for starting this case. So just to make sure we're all on the same page, because I think facts are really important. And in another meeting, I'll try to explain why Norm is wrong about children as kidney donors, but that's a different statement. I'm focusing today on stem cells. So there are stem cell donors can come either from bone marrow. We can actually collect stem cells from peripheral blood. And as Norm explained, we can get blood from cord, like in the Ayala case. Generally, you get the best results if the donor and recipient are HLA matched. Siblings have a 1 in 4 chance of being matched. Neighbors are actually unlikely to match, which is why we often turn to siblings. Right? So what are the risks? First, the risks of a bone marrow is that oftentimes, particularly in young children, you're going to need to procure it under anesthesia, and anesthesia is not without its risks. There are also some short-term adverse events, including fatigue, pain at the donation site, low back pain, difficulty walking, problems sleeping, and the children may actually need a blood transfusion. There is some potential more serious as if you, during the procurement, if you hit the sciatica nerve, but in general, considered, as Norm said, relatively minimal risk. Peripheral blood, you need to be able to put 2 large gauge needles into the child. In children, this may again require a central line. It may even require anesthesia, again, with its concomitant risks. And again, the child may need a blood transfusion. And finally, cord blood is actually, there should be no risk if cutting the cord is done according to standard practice. So overall, then, I think we could all agree, relatively minimal risk. We often will use, though, GCSF to stimulate more stem cells, especially for peripheral blood stem cell collection, and this has its own short-term risks: splenic rupture, fatigue, back pain, difficulty walking, sleeping problems, and the long-term risks, and here's the important thing, are uncertain. There's possibly an increased risk of leukemia. Despite that, I still think from a physical side, we can call the risks probably at the level of minimal risk. But then we have to talk about the psychological risks. And one of the reasons that I got so involved in writing the statement from the American Academy of Pediatrics is that donors, and not just donors like LR, but many donors feel neglected because they become a patient the moment they get HLA typed, the moment they undergo the procedure, and yet all the focus is on their sibling, who's the ill sibling, who's now going to be the recipient of the stem cells. And to the point that at some institutions, traditionally, the donor didn't even have their own medical record. All that information was put into the recipient's chart. So there's been this failure to acknowledge that the procedure, from the day that we take the kid and try to do HLA testing through the donation, is a patient as well. And the data show that if the recipient doesn't do well, that the donors blame themselves. And this data actually exists both regarding pediatric donors as well as adult donors. There's a lot of feeling, not that the bone marrow transplant failed, but that I failed. And I think we have to acknowledge that. So at this point, you have to say, is it a minor, is it a minimal risk? In the research ethics terminology, is it a minor increase over minimal risk? I think we could say that blood donation is purely minimal risk, but when you add up both the physical risks and the psychological risks of being a stem cell donor, it's probably more like a minor increase over minimal risk. So more than being just a blood donor, less than being a kidney or liver donor, for which children have been donors historically, although much less commonly in the last 10 years. What are the benefits of being a stem cell donor? There's no physical benefit. There's potential psychological benefits, right? We saw the beautiful case of the Ayala sisters, who are really best of friends, and one sibling was able to save the other's life. But again, it's all good when everything goes well, much more complicated when the recipient dies. So some of you may be saying, but isn't there the good feeling that at least I tried, at least, we gave up my sibling that, the benefit of a doubt, the last chance and things of that sort. And it sounds good, except when you look at the literature, it shows that the donor's quality of life and determination of their own well-being really is very dependent upon how the recipient does. So now, having given that type of background and seeing where I perceive the risks and benefits of a stem cell donation, I want to return to Doug's 4 questions. So question number 1, should prisoners have access to costly medical interventions? How should clinicians and consultants manage their potential conflicting feelings? Should a minor sibling be permitted to act as a transplant donor when the recipient sexually assaulted her in the past? And should parental permission for the use of bone marrow obtained from a minor sibling be considered valid? And what are the broader policy implications for the sibling donor bone marrow transplant? So the first question, the whole issue of access, should prisoners have access? I'm going to say yes, if clinically indicated. And for those who are hesitating that my answer was so definitive, right, at least for this case, the real question is whether incarcerated youth should have access to costly medical interventions, right? So I'm not talking here, and I emphasize the youth because AR was tried as a youth and has been healthy. He would have been released from prison as a young adult. And so I'm not here talking about cases of people who are on death row, although I have to confess that from my own perspective, I would still argue that they should have access to costly medical interventions, including bone marrow transplant. Again, remembering that this is about bone marrow transplant, I'm not talking about liver or heart transplants, although again, I probably still would answer yes. So I don't think that being a prisoner should have any impact on what type of medical care that AR gets. Now, the issue of how should clinicians and consultants manage their potentially conflicting feelings, we just spent 20 minutes getting depressed. I'm going to skip this part of the questions. And I'm going to focus on Doug's last 2 questions, which I think are the ones that I find the most complicated and the most ethically challenging. So should a minor sibling be permitted to act as a transplant donor, and should parental permission be adequate? And I'm actually going to reframe those questions into 4 separate questions, which is, when is it ethically permissible to ask children to serve as bone marrow donors? When it is not permissible, whose responsibility is to protect a potential child donor? Is it ever ethically permissible for an individual to donate to a recipient who sexually abused him or her? And what are the appropriate next steps? So when is it ethically permissible to ask a child to serve as a stem cell donor? Here I'm pretty adamant that it should only be within an intimate, functional family. Clearly this is not the case. Because then the child donor has the greatest chance of the psychological benefit, right? With the Ayalas, Anissa was not thrown out with the bathwater. She became a very important member of the family. She and her sister have a wonderful relationship. It's an intact family where there's great potential that, in a sense, she can revalidate the decision of her parents at all steps. And here, it also has the potential to benefit the whole functioning of the family. Having a child die causes dysfunction in all families. It's very hard on them. And so it's for actually the siblings' indirect benefit to actually keep their other sibling alive so as to keep the family healthier psychologically. And biology also justifies it within an intimate family because that is the case where you have a real 1 in 4 chance of being an HLA identical in contrast to neighbors or cousins or other third-degree relatives. So why is it okay for parents to consent for both the child donor and the child recipient? Is there this concern about conflicts of interest? And the objection is that, right, the parents have a conflict of interest, but I would actually argue that parents are the appropriate decision makers for all of their children, even when their children's need conflicts. This happens every day. I have to drive one child to an activity and I have to drag the other child because I'm not gonna leave the child home alone, and the child says, but it's not in my interest, and we can get in a car accident, I can die from it. I'm still taking the other child in the car. While we claim to hold parents to, quote, a best interest, I can't serve both of my children best at any moment. And in fact, if you read probably the best book on surrogate decision-making, Buchanan and Brock's book, Deciding for Others, what they'll say is that best interest is really a regulative ideal, that we really don't approach that, and if anything, we actually let parents make good enough decisions, and in fact, we don't intervene until parents make bad decisions, right, when they reach some threshold of harm, of abuse or neglect. And so the question comes, can parents make decisions that promote the best interest to being a bone marrow recipient and then expose their child to some harm, the donor to some harm? And the answer is yes, provided that they don't harm the child's basic interests. And obviously I'm going to argue here that we actually harmed LR's basic interests. I'm going to skip through this one. So why is it okay? Again, parents, as I'm arguing, it can compromise the interests of one child for the benefit of the other, all within an intact or intimate family, because there, in a sense, is going to have to be lots of compromises as we go through life. And because, as I've already tried to argue, that the interests of the donor and the recipients are really quite intertwined in the sense that overall it is better for both children to have living siblings so that their parents aren't distressed by having to deal with the death in a family. And parents need to have discretion in child-rearing decisions, provided that they respect each child as the developing person that he or she is becoming. So there really has to be, from the parental perspective, there has to be both a respect for the individual the child is becoming, as well as a need to fulfill the child's basic interests. And I would argue, I'm not sure that either of those were fulfilled by AR and LR's mom. So what's the problem with AR and LR's mom authorizing LR's HLA testing? Whoops, did I go ahead? Okay, yes, okay. So mom and AR consented to the bone marrow transplant for AR, and mom clearly can make that decision that she feels it's appropriate, and AR is an older teen, and so his assent was sought. And LR is found to be an HLA match. And here where I think is the problem was that she was tested before any discussion happened. And in a sense, by the time we find out she's HLA identical, the train has left the station. Really much harder to stop anything once we know we have an HLA match. And so my whole argument will be that we really need to think of the child. The day we bring the child to the doctor to get HLA testing, the child is a patient, and that patient deserves an advocate, someone who's looking out for their medical interests, and clearly that's what didn't happen in this case, right? And so I would argue that HLA testing should have never been done on LR, and had we not known that she was a match, we would have continued to search in the international registry. If no match was found, they could have decided to try an HLA haploidentical. Mom could have tried to be a donor, probably less successful results, although in this case the results were unsuccessful in the long run anyway. But once you know she's a match, there's no reason or sort of, we've lost all incentive to look further. There are over 7 million individuals on the International Bone Marrow Registry. That doesn't promise that there is a match, but again, as I said, we have gotten better with haploidenticals, particularly in teenagers. And if we fail to find the match, AR can try alternatives like chemotherapies. It was actually mentioned in the case, in the fuller length of the case, which Doug had published in the Journal of Clinical Ethics, that this was actually proposed to the family, but they chose the bone marrow because it had a better success rate than the chemotherapy. And yet again, to not harm the basic interests of LR, we could have gone with with chemotherapy. But I'm going to keep reiterating this point. Once we know she's an HLA match, the train's left the station, and we're just going to end up trying to figure out how we can justify having her participate as a donor. And so I think it's not that HLA testing, it's a blood test. I agree, it's minimal risk no matter how I slice it, but it's that HLA testing should not be viewed alone. It should be part of the whole stem cell donation process, and when viewed in that sense, it has more than minimal risk. And at that point, we have to decide whether mom is the proper person to be authorizing for LR. So having argued, in a sense, that mom cannot authorize LR's HLA testing, even though she can authorize other treatment for LR, right? It's not that I'm taking away mom's rights of parenthood or anything else. It's just that in this case, what she's looking for is not to what's in medically best for her child, and that's not even in her child's basic interests, but really what serves the other child, a child who has sexually assaulted LR. And so therefore, in a sense, by doing the HLA testing and proposing her to be the donor, in a sense, we're committing a second assault on LR. It's the only way to think about it. We're going to take her to the operating room. We're going to put her under anesthesia to collect her bone marrow, but it's still a second assault. Now, some of you might be thinking, well, isn't she allowed to forgive her brother? And I will come back to that, because I do think it's an interesting question. But I would actually argue in the case of a 9-year-old, no, I don't think she has the maturity and the capability to do true forgiveness, and so therefore I don't think it's appropriate to be asking her to be forgiving in this situation. So when it's not permissible to do HLA testing, whose responsibility is it to stop before the train leaves the station? And the answer is, first it was mom's. Mom failed. Then it was the obligation of the healthcare team. But we viewed HLA testing, we the healthcare community, as a minimal risk procedure, and so we proceeded. And again, I think that's where the mistake happened, that in a sense we all failed LR in this case. So at minimum, the team has to insist upon a complete psychological workup, right? We hear that LR has never gotten psychological counseling. Mom wouldn't allow the team to discuss the assault with her. Mom wouldn't leave the room when we were doing a psychological assessment. And so in a sense, LR really never had a chance to even discuss some of the fears that she was feeling and whether she was feeling as if she was being assaulted. And so in a sense, again, we collaborated or corroborated with mom to, in a sense, the second assault. Now, if the team had only learned about the assault after we had HLA testing, I still think we should have figured out a way to have stopped the process from going forward. It was still inappropriate to have LR serve as the donor, although I think it would have been much harder. And that's one of the reasons why in the statement that the AAP will write, I will argue that we really have to get a donor advocate involved before the HLA testing, because it's a lot easier to stop things at that point when really there's a lot of uncertainty about whether she could serve as a bone marrow donor. Is it ever ethically permissible for an individual to donate to a recipient who sexually assaulted her or him? And I do think that there can be situations where a mature adult can forgive the person who has assaulted them. But my position here is that LR has never really had a chance to do any type of psychological assessment of what has happened to her, has had no opportunity to really understand this, even from the level of maturity that a 10-year-old could have in this situation. In Forgiveness and Mercy, there's a book by Jeffrey Murphy. He argues that a person who does not resent the moral injuries done to her is almost necessarily a person lacking in self-respect. And in a sense, we, fostered this lack of self-respect on LR by not allowing her to resent the moral injuries that her brother committed, but instead, in a sense, recommitted them. So she should resent her brother. And for one's mental health, though, one should be motivated to overcome one's resentment. But that's going to take a lot of psychological work, and it's not going to happen until she gets a lot of counseling, some private counseling without mom in the room, and is able to, in a sense, think about all of the events that brought her to this moment. And that, I should mention, it's a very interesting book where they talk about that even if she overcomes resentment, it doesn't necessarily entail forgiveness. A competent adult may choose to forgive, which is a moral action, whereas just overcoming one's resentment is more of a psychological way of handling distressing situations. But forgiveness actually requires a moral action. Liberating oneself from resentment is an expression of one's own dignity. But again, this is a child who's really never been given the self-respect to address the fact that she was assaulted by a family member. So we really, before we can expect anything from LR in this regard, we really have to give her the chance for counseling, self-reflection over a prolonged period of time, not in the period of time from HLA testing until the transplant takes place. LR's mother refused to allow LR to undergo a complete psychological workup, and so it seems unlikely that she could have gotten even to the point of lacking resentment, but clearly not being able to get to the point of forgiveness. So basically, morally, LR should not be HLA tested, and even if HLA tested, LR should not serve as a bone marrow donor for AR. I just want to state at this point that Walter and I, Glenn and I, ended our commentary, which goes over many of these points in more details, with these words: we owe LR an apology for ignoring her own needs in an effort to save her brother. We owe LR the protection afforded to the rest of us to avoid exploitation. We owe her a promise that transplant centers will develop policies to ensure that no future potential donors will be asked to do what she was forced to do, to serve as a bone marrow donor when it was contrary to her self-respect and potentially contrary to her basic interest. And it was in light of this case that it actually led me to propose to the American Academy of Pediatrics that we needed a statement on hematopoietic stem cell donors. And so I also want to thank here Steve Jaffe, who I worked with for over 2 years, although in the end he asked to have his name removed from the statement. But I still want to acknowledge his contribution because it was important to have somebody who does stem cell transplant to truly understand the risks and benefits of the procedure. And what we came up with was that there are 5 criteria that must be fulfilled for minors to ethically participate as stem cell donors. And these were that there's no medically equivalent histocompatible adult relative. And we realized, given time constraints, that you might not want to do adults first and then children, but everybody might get assuming that appropriate candidates might all be tested at the same time. And if 2 were HLA identical, preferring the adult over the child, preferring those who have decisional capacity over those who may have decisional incapacity, but yet the time necessity, meaning that many people may be worked up at the same time. We felt that you needed to have a strong and positive relationship between the donor and recipient, that there would be some likelihood that the donor will benefit, should not be done when the likelihood of success is remote, and finally, that the clinical, emotional, and psychosocial risks to the donor be minimized and reasonable in relationship to the benefits expected to accrue to the donor and to the recipient. And so we encouraged actually the notion of a living donor advocate or some similar mechanism that would be with LR or some other potential sibling donor from the beginning to make sure that it made sense to go ahead even before the HLA testing was done. We did not mean this in an adversarial way. We did not feel that this needed to be a court type of situation, but what we really meant the donor advocate to be was to be basically the team for the donor, so that as everyone focused on the ill recipient receiving this bone marrow or these stem cells, that somebody would be there to remind everyone, hey, remember there's a patient 2 doors down as well. The child who gave the stem cell donors, who was healthy before she went to the OR, is healthy now, but still is a patient. And that can really get lost in a family when one child is quite ill and dying. So had LR had a donor advocate, she would not have undergone HLA testing, and even if she had undergone it, the donor advocate should have had the power to prevent it. I know I've run out of time, so I'm just going to skip ahead and get to the end. But this isn't the only case in the literature to show that we have, in a sense, used stem cell donor siblings without really thinking about the emotional consequences. There's another article actually presented by Kesselheim and Jaffe of a child where they asked a child who was relinquished for adoption, who, when the child gets sick, the biological children are HLA tested without any consideration, again, of the fact that there was no intimate family. There was a lawsuit in Illinois called Bozan versus Curran, where a father of half siblings wanted the half siblings to be tested. And the most important part of that court case was that the court argued, and the father kept saying, but it's minimal risk to do HLA testing, and the court insisted that you could not separate the HLA testing from the whole process, and that bone marrow donation was not minimal risk, and so therefore you shouldn't start down that pathway unless you're going to approve the bone marrow transplants, and they were not going to approve the bone marrow transplant. So these are rare cases, and they should be. The proposal for a living donor advocate was not meant to interfere with the vast majority of sibling donations, although I still want to just continue to reiterate that I think it has more psychological risk than it has been acknowledged in the past. At least that's what the literature shows, and it's something that we need to think about as we expose these children to these risks. How are we going to minimize those risks? And part of it is to make sure that the donor has his or her own medical team behind her. The donor is a patient. And so let me end on that note. It's different than solid organ donors. That's another fight for Norm and I to have at another time. Minors can morally participate as stem cell donors if the 5 criteria are met. The responsibility for ensuring that these 5 criteria are met belong to both the parents and the healthcare community, including a living donor advocate. And hopefully the AAP statement will protect children like LR in the future. Thank you very much.